Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. Welcome to yet another primary snippet. So, Maddie, today we are going to dive into a slightly rare topic which has not been asked that frequently in primary, that is obesity. So, can you please define morbid obesity and outline the cardiovascular changes associated with morbid obesity?
So, morbid obesity is classified as having a BMI of greater than 40 kilos per meter squared or a BMI between 35 to 40 with at least one medical comorbidity related to being overweight. So, there is actually a lot of changes that occur with morbid obesity on the cardiovascular system. So, we can divide this into the cardiac preload, the left heart function, right heart function, cardiac output, pulmonary circulation, systemic circulation, coronary circulation, and then the cardiac conduction pathways. From a cardiac preload point of view, there is increased preload and CBP, and this is thought to be because of the adipose tissue has more leptin, which activates the renal angiotensin system and causes angiotensinogen synthesis, which results in salt and water retention and increases the total blood volume. And the pathogenesis of the increased total blood volume, some of it is a bit unclear, but the thought is that maybe also because of the increased metabolic demands from the increased fat, it causes an increased total blood volume. From a left heart perspective, in morbid obesity, there's generally increased left ventricular thickness and chamber volume. And this is because of increased preload plus usually increased afterload causing remodeling. And diastolic function is often impaired with an increased end diastolic left ventricular filling pressure. So these patients are more likely to suffer heart failure with actual preserved ejection fraction and have more of a diastolic dysfunction. And this is thought to be because of myocardial fat accumulation and fibrosis. From a right heart perspective, there's increased right ventricular afterload. So this is generally because of some of the hypoventilation and respiratory syndromes associated with obesity, such as obesity hypoventilation syndrome or OSA, which causes hypoxic vasoconstriction, and also because of left ventricular dysfunction and the mechanical effects of that causing increased intrathoracic pressure and increasing the right ventricular afterload. The RV dilatation occurs because of the higher blood volume and the increased RV afterload, and there's RV systolic function due to this chronic volume overload and increased epicardial fat and afterload. And similarly, there's also RV diastolic dysfunction like LV diastolic dysfunction due to increased epicardial fat. From a cardiac point of view, there's initially an increased cardiac output and more of a hyperdynamic circulation. This is mainly due to increased stroke volume because of this increased preload. But subsequently, this decreases depending on the degree of systolic or diastolic dysfunction that occurs. And from a pulmonary circulation point of view, there's increased pulmonary vascular resistance. And this is because of some of the mechanisms we talked about in terms of with the increased RV afterload. So there's chronic hypoxia, secondary to the respiratory dysfunction with OSA or obesity hyperventilation causing chronic hypoxic pulmonary vasoconstriction, and also because of left ventricular diastolic failure. From a systemic circulation perspective, the SVR can be increased or decreased. So the decreased mechanism is generally from the fat vascular beds, which are added in parallel, which decreases the resistance. And from an increased SVR perspective, there's an increased incidence of hypertension due to chronic sympathetic activation and activation of the renin-angiotensin-aldosterone system. There's been multiple studies that show that there's a reduced ability for patients with morbid obesity to vasodilate in response to any sort of physiological or pharmacological stimuli. And the thought is maybe because there's decreased nitric oxide production and maybe responsiveness. And there's also accelerated atherosclerotic disease in the circulation as the fat activates inflammatory processes and promotes endothelial dysfunction and insulin resistance. So they're more likely to have things like peripheral vascular disease and coronary artery disease. And there's more venous insufficiency, maybe because of increased intra-abdominal pressure and venous stasis. From a coronary circulation, we know that there's accelerated atherosclerosis, as we've already discussed in the systemic circulation, but there's also coronary microvascular disease that occurs because of this chronic inflammatory state and reduced ability of arterial vasodilatation, causing decreased myocardial perfusion. And then finally, from a cardiac conduction point of view, the heart rate generally stays the same or can be increased due to myocardial fat deposition, autonomic dysfunction, and increased catecholamines. There's an increased incidence of atrial arrhythmias, such as AF, and also ventricular arrhythmias. The atrial ones are because of left atrial and RA, increased pressure and dilatation, and maybe because of OSA. And the ventricular arrhythmias are because of remodeling. On ECG, you might see things like left axis deviation, long QT, increased PR, bundle branch blocks, or AV blocks. And this is because of fibrosis and fatty infiltration of the conducting system. So there's a lot of pathological effects that occur in relation to morbid obesity.
Thanks, Mary. So that's the end of our today's primary snippet. We'll be back with another snippet in month's time. Till then, goodbye and have a nice time.
Thanks for listening, and see you next time.